Okay, well, let's go ahead and start our webinar this morning. Thank you all for coming. This webinar is focused on community health and their interface with primary care and where primary care providers may see them, kinds of services that they're providing. We want to remind you that this webinar is being recorded, and if you are on the telephone, plan to mute yourself. If you're using your computer's microphone and speaker, that's the word I'm looking for, please go ahead and be sure that you mute your microphone so that we aren't listening to you key and so we don't get circular feedback that can happen in those kinds of settings. This webinar will be recorded if you stay on. We're assuming that anything that you type in the chat box and anything you say can be recorded and is okay. I'm Kate Cross, and I'm the Transitions Improvement and Health Systems Consultant in the Office of Healthy Communities. And with me today is Adriana Avalar, who's our technical assistant, and she's a WIN project coordinator. In order to ask questions, let's talk about this. At the top of your screen, you'll see a little man with a hand raised. If you click on that, it will raise your hand in the webinar, and we'll be able to see and call on you to tell us your question over the phone. If you'd like to talk your question or type your question, you can type it in the community chat box. Those questions are visible to the entire audience. If by chance you have a TA problem and you're having problems with your computer some way, you can actually click on Adriana's name, and it'll create a private chat line just to her, and you can let her know what your problem is, whether that's loss of sound, loss of image, whatever that is, and we can help you get that addressed. So welcome again to the Community Health Workers and Primary Care webinar for the WIN Institute. For our patient-centered medical home collaboratives, we're working on 8 change concepts in the clinics. This webinar is going to be connected to the quality improvement strategy because the evidence is showing that community health workers have the potential to be improving the quality of care for patients. It connects with patient-centered interactions. It's tied to organized evidence-based care, and care coordination is one of the key roles that is frequently done by community health workers. This morning in our agenda, we'll be doing some introductions here at the beginning. Then we'll be hearing from Scott Carlson about community health workers and the evidence base for that and some of the things in terms of regulatory information and what the current status is in Washington State. We'll have a panel of experts, people who are working with community health workers and their organizations, to answer some questions for us. We'll be taking some questions and answers from the audience. We'll probably do those several places through the course of the presentation this morning, so go ahead and type your questions in as you have them, or jot them on a notepad next to you and then raise your hand and we'll call on you. And then at the end we'll be doing an evaluation and getting you set up to get some CME. So thank you again for coming, and let me introduce Scott. Scott serves as the Community Health Training System Manager for the Washington State Department of Health. He is responsible for providing oversight for training activities for community health workers, and he works closely with the Practice Improvement Unit and the Heart Disease, Stroke, and Diabetes Prevention Programs to identify strategies for effective utilization in community health workers and improving health outcomes. So with that, I'm going to pass it on to Scott. Before we do, we have one poll question, and we want to get some information. So on your screen, I'm sorry, go ahead. On your screen, you'll see a question about how would you rate your knowledge and awareness of community health workers? Are you very familiar with them? Are you somewhat familiar with them? Are you not at all familiar? It's kind of a new concept and you're exploring it. So it looks like most of our audience is fairly familiar with them. I'll give another minute or two for people to go ahead and respond a little more. Any more answers out there? Okay. So we're working with a fairly familiar audience here. I'll turn it over to you.
Okay, thank you, Kate. Good morning, everybody. This is Scott Carlson with the Washington State Department of Health. Thank you so much for taking some time this morning to participate in our webinar. We really appreciate that. As mentioned by Kate, we are here today to discuss community health workers, and more specifically, some examples of their roles in primary care. Before we get to our panel, I wanted to provide some background information as to why we are talking about this subject. Community health workers as many of you know, have been around for a very long time with a long and rich history of providing services in local communities. However, the Affordable Care Act has placed a renewed emphasis on the utilization of this workforce in addressing some of our most challenging health issues relating to health disparities and chronic disease prevention efforts. More importantly, a wealth of new evidence-based data has been released over the last 1 to 2 years that really demonstrate the value of their role, including return on investment data, in some cases showing a 3-to-1 return on investment. A link to some of these resources will be shared later in the presentation. Next, please. In Washington State, we are in the early stages of a 5-year healthcare innovation model that is referred to as the Healthier Washington Plan. The State Healthcare Innovation Plan is supported by legislation signed by Governor Inslee in 2014 and a federal grant from the Center for Medicaid and Medicaid Innovation, sometimes referred to, Medicare and Medicaid Innovation, sometimes referred to as the Washington State SIM grant. It is interesting to note that currently in Washington State there are limitations. Well, really, there is no official definition for community health workers, including their scope of practice, roles and skills, and training requirements. This ambiguity can often limit their potential role in the healthcare delivery system. To address some of these challenges, the Healthcare Authority, in partnership with the Department of Health and other state agencies and community partners, has convened a Community Health Worker Task Force. The Community Health Worker Task Force, which was launched in August, has pulled together community health workers from across the state as well as community health worker stakeholders to really sit down and work together in identifying the roles, attributes, and training recommendations for community health workers. The Community Health Worker Task Force has a nice website on the Healthcare Authority's webpage, which I've listed on the slide for more information. I would encourage folks to visit that webpage to learn more about these efforts. It's also interesting to note that community health workers often serve under multiple job titles, which can sometimes cause confusion for those who work or partner with this workforce. In particular, Promotoras and community health representatives have a long and rich history in working with Latino and tribal communities, respectively, in this line of work. For the purposes of this presentation, we are going to use all of these definitions in referring to community health workers. Nationally, there are several recognized community health worker definitions that are often referred to in describing the roles of community health workers. 2 of the more common utilized definitions come from the Affordable Care Act and the American Public Health Association, which we've listed on this slide. Although they are worded differently, the underlying meanings are very similar. If you look at the bolded text, you can see that CHWs are really frontline workers with a unique understanding of their community, often reside in the same neighborhoods they are serving. They are natural liaisons who advocate and assist in supporting clients in cultural and linguistically appropriate manners. CHWs serve in many roles, and the task force is currently working to identify the most appropriate or ideal roles that CHWs play in the healthcare system. This is not a complete list, but gives examples for the purposes of our discussion. As mentioned in the slide, roles lead to expectations that help determine the overall responsibilities that CHWs can play in an organization or healthcare delivery system. Breaking it down further, the CHW task force is also identifying the skills of CHWs. For example, communication or language skills. These defined skills help the CHWs perform their roles. That right there concludes our brief overview of community health workers in preparation for the upcoming panel. Listed here, you will see some resources with links on the lower left-hand side of the page. Again, I would encourage you to review these links at your convenience. There's a wealth of information contained in them, and so with that said, I'm done with my section, and we're going to move on to the panel.
Thank you, Scott. So today we have, excuse me, today we have several panel members. We have a couple of people who are from coordinated care that will be representing coordinated care as well as kind of the payer community as a whole. And then we also have some people from CMAR Community Health. and I'm going to ask for introductions. If we can have the four of you, we're going to start with coordinated care, and Norma, maybe we'll let you go first. I've got to give you several assignments here in your little intro. We'd like a couple of sentences about you personally, your organization, and then a little bit about how long you have worked with community health workers in your organization. So Norma, can you start us off?
Sure. Good morning, everyone. Thank you for inviting us to participate today. I am with Coordinated Care, and our program is called Member Connections, and we manage the community health workers that work with our members throughout the state of Washington. And our office is based in Tacoma, Washington, for those of you that are not familiar with us. And I personally have been working either as a community health worker or with community health workers for about 25 years. And of course, as Scott had mentioned earlier, we have been referred to by different titles throughout the career. And we have been in existence here in Washington State a little bit over 3 years. And we're really excited to be part of the Healthy Innovation and Healthier Washington CHW Task Force and doing the hard work to really get these definitions down for roles, skills, and responsibilities. And I would like to introduce Amber Stokes, who is one of our community health worker leads.
Hi there, my name's Amber, and I am a community health worker for Coordinated Care. And I work primarily in King County North, all the way up to Skagit and Island County. And I have been working with Coordinated Care now for over 3 years. And I have a background working in human services and also working directly with the underserved population. So thank you for having me here today.
Thank you very much. Colleen, can you tell us about you and have David introduce himself from CMAR?
Yes, definitely. So my name is Colleen Pacheco, and I'm sorry, can you hear me?
If you can get a little closer to your microphone, it would be helpful.
Okay, can you hear me now?
Not very well.
Okay, hold on. Let's try this again. Can you hear now?
Ah, there we go.
Okay, so when we're talking, we can't, the other person can't hear, so, but we should be able to work on this way. So CMAR is, as you all probably know, we're a community-based organization providing comprehensive health, human, and housing services to diverse communities, but we do specialize in service to Latinos. We started in 1978 with one clinic, and now we have over 90 sites in 10 counties, like 24 medical clinics, 14 dental, 16 behavioral health. We have an intergenerational assisted living facility, 3 pharmacies, 3 inpatient treatment centers, a plethora of preventive health and community services and programs from health education and MSS and WIC to homeless case managers and a farm worker Promotoras program and Spanish language radio and ESL and citizenship classes, etc. The majority of our clients are at 150% of the federal poverty level, and let's see, but we do try to hire staff that are reflective of the local communities at each of our sites. I have been with CMAR for about I think about 8.5 years, and I've been working in some capacity with community health workers and their various titles and roles for about 7.5 of those years, managing different programs. And I currently manage 2 programs that do utilize community health workers, though they're not called that. And I'd like to introduce David, who is our health educator, who's one of our community health workers.
Thank you, Colleen. My name is David Renteria, and as Colleen mentioned, I'm a community health worker, and my particular type of community health worker status is health education. I work directly with community members with chronic diseases to improve their health. I do this through multiple modalities. For example, I can connect them with community resources. I provide evidence-based interventions and health opportunities for them. I engage with them for community health needs assessments, and I provide continual support and accountability. My sessions with them are usually about an hour long, and they're either one-on-ones, group, or by phone. And I've been doing this work for the past 1.5 years.
Terrific. Thank you so much. And actually, in the process of doing that, we answered a few questions that we'll come to later. But let's go ahead and talk about these questions. I'm going to try and I'll address names, so that will keep us from talking over each other. Before we do that, let's ask one more question of the audience here. We want to check and see if they are currently working with community health workers in their organizations. We have a couple of responses, and they both do. And we'll give just another 30 seconds or so here so people can respond. It looks like many of you are working with community health workers in your organizations, but there are some people who, like myself, would have been unsure until I learned a little bit more about it and knew who to ask. So let's go ahead and ask some questions and learn some more about how people are doing. So Colleen or David, the first question is for you. Within your clinic, how are patients referred to a community health worker? Are they, does everybody get one, or do they go to particular patients, and how is that decided?
Well, first I think I should say that our community health workers are in like 7 or 8 different departments, and so they get their patients through many different ways, be it by meeting them in the community or by being referred, having referrals from other staff members. But the 7 or 8 different departments, we utilize them in, as I mentioned, they all have different titles, roles, and responsibilities, but we only have one specific position that within one department that utilizes many different community health workers. Only one of them is actually called a community health worker, and that's in our maternity support services. The other 3 members of that team, which is an RN and a social worker and infant case manager, are also community health workers, but the one that's labeled a community health worker is responsible more for the outreach and setting everyone's schedules. But we have, the other departments, our health education, as David will talk about a bit more, and our care management team, the care management team is something that's relatively new to CMAR in the last few years, and that, those titles are all completely different too. But they work with a specific list of high ED utilizers who also have medical and behavioral health issues, I believe, and they work on trying to obviously address them, help them improve their health by advocating for them and helping them really put their health plan into action. But they're out in the community as well, and they get their patients both from from providers in-house, but mostly from lists that the insurance agencies give them. There's also, we also have our managed care team, which are the inpatient navigators, now called, I believe, something else, community resource navigators, and now maybe something else even, but they're the ones who are primarily responsible for enrolling patients. And they can be referred either when patients come to the clinic or when they just show up because they want to get health insurance, and we send people in to see them. And there's also more that are out in the community going to outreach sites trying to sign people up. The homeless case managers, we see homeless throughout our entire network, but up in Skagit and Whatcom County, we have case managers that work more closely in the community, as well as they have office hours, but they're definitely out in the community trying to help connect individuals who are homeless or on the brink of homelessness with additional resources and advocating for them in different ways, not just health, but just all the different ways in which enabling services that individuals may need to move further to become more stable in their life
Colleen,
and improve their health outcome. Yes?
Which ones of these various groups would be interfacing with primary care providers?
I think all of them will be interfacing with them. David can certainly talk about it as a health educator, even though he's out in the community a lot. He also sees patients in the clinic. Would you like me to go to him right now, or I can also talk a little bit more about other groups that we have.
Let's go ahead and hear what David has to say in terms of how he interfaces with primary care, because we're interested in the information that if I were a provider in a primary care clinic, I would be helpful as I'm providing care for patients. Does that make sense?
Yeah. So the PCPs will usually see patients, and then if they feel that they have a need for my services or continual follow-up for long-term health outcomes, then that's when they enter a referral for me. Usually they use the MAs to enter the referral, and then sometimes they even have me come into the patient room to do a brief introduction, and so that they can put a name to a face. And then typically what will happen then is that the patients will go to the front desk and schedule into my schedule. And this is one of the best practices, because once the patient, or at least in my experience, once the patient leaves the clinic, they're not as likely to come back for these adjunct services. So it is kind of crucial to get them while they're in the clinic if we're talking about in-clinic patients. But I also see a lot of community members, and sometimes I do community groups, I do community partnerships, and I invite current CMAR patients to these community events. And then through word of mouth, other community members will arrive, and sometimes they're not always CMAR patients. And yes, let me know if I can add anything to that.
Okay, thank you. And Norma, can you tell us a little bit about how it works from the payer side in terms of how patients get referred and where primary care, they may interface with the primary care clinic?
Certainly. Can you hear me?
I can.
Okay, great. So there's a couple different methods that is used. Now internally, we have a lot of our members that are working with our care managers, which are nurses, and the nurse may refer one of our community health workers to meet with a member and either connect them back to primary care, and maybe they might need some additional resources, in the community as well. It might be as well as connecting to oral health or housing, might be basic needs that they might need as well. And there's also a method that providers can go through their web portal, and they can actually make referrals directly to our community health workers for a specified list of things, like if they've missed appointments, if they've not picked up medications, if they've lost contact with them. And we can go out and find the members for them and reconnect them back to primary care. One of the things that we started trying this year as well for folks who wanted to engage with providers but maybe might have some barrier, whether it's either shyness or maybe not sure how to communicate appropriately within a provider network, was doing some health coaching with them as well, which is a combination of chronic health illness education and or just getting them familiar with processes of using their insurance. One of the things that I'm sure everyone would agree with is that a lot of folks that came on board through the Affordable Care Act had either not had insurance for a long time or had been quite a while since they had. So just relearning the system, and so we identify a lot of our members that have never engaged with a PCP, actually help them make the appointments, getting them to use calendars, getting organized, helping with transportation needs, and helping them schedule that. And we can actually also meet them at the PCP office initially, just to give them a little introduction to the provider or the clinic, and just assist them with any other type of resources they may need, just to get them more comfortable, and to also just talk about the importance of keeping appointments, and the time being reserved to them, and just going through just overall guidance of the appropriate way to use a PCP and how it's going to benefit them to achieve better health.
Okay. And
one of the things too that we've also done too is our partnerships. One of our large areas of concentration of members is in the Yakima Valley. So we've partnered to do a lot of member-facing events that are specifically focused, for instance, with pregnant women, and talking about prenatal, postnatal care, and as well as well child's oral health, lactation, just a lot of health subjects. And so we work with our provider partners very closely to do that education with them so that everyone's involved.
Great. Does Amber, do you have anything to add?
I think Norma pretty well covered it, but really just emphasizing being in the home visits with our members. There's such a great opportunity for education and empowering our members to interact with their primary care providers and to really learn how to connect with them and ask the right questions and be prepared to interact with them. So, yeah.
Great, thank you.
Mm-hmm.
I have a follow-up question for Colleen. Colleen, do you know if you all use the provider portal to refer any patients to payer community health workers, or do you all work primarily internally? I think you may be muted currently.
Yeah, sorry.
No
Well,
worries.
are you referring to provider 1 with DSHS?
That's a good question. It sounded like Coordinated Care has their own provider portal for their members.
I don't know. I turned over a clinic management a couple years ago, and I don't know what they're doing now, so can't answer that.
That's fine. That one wasn't actually on our list of things that we sent out to you in advance either. Okay, so this question is for Coordinated Care. Actually, never mind, you've answered it already, and that's part of what led to that follow-up question. The question was, if I'm a provider, how would I get help from you with a particular patient? So this is for everybody, and let me read the question first, and then we'll have somebody respond. So the question is, do community health workers have a limit to the amount of time they can spend with a patient? And the question kind of has two aspects. One is, David was talking about he sets up hour appointments. Is there a limit to the frequency of those or anything like that? And then the other question is tied to when you do have a community health worker working with a patient or a member, is there a time limit in terms of 3 months? Do you do it in increments of a month and then decide to renew? How does that work? So let me go ahead and just kind of pull the group here. Colleen, let's go with you first. I think you were on a minute ago.
Yeah, hi. Well, so it really, as I mentioned, there are 7 different departments that utilize community health workers, and based on the rules and parameters and their focus of their program, they have many different, it's wide-ranging. David can talk about what they do, but certainly like in care management, their average visits are 30 to 60 minutes, and it really just varies. It might be for the initial visit, they can meet with them for up to 2.5 hours, but then other visits might be 30 or 60 minutes. It depends on what the role is. So without going into the specifics of different departments, I'll let maybe David talk about right now about health education.
All right, so because I have other responsibilities, including program planning, literature reviews, data analysis, continuing education and training to stay current, team meetings, marketing, charting, and more, time management is of the utmost importance in order to be able to reach my productivity goal of 108 encounters per month, where 3 encounters with the same patient count as 3 encounters towards my productivity.
Okay.
And with regards to longevity of relationship, that really depends on the particular needs of the patient, as well as the defined structure of the intervention or curriculum that I'm using. So my position is aimed more for long-term health outcomes. So, for instance, I've had a patient that was able to quit smoking within 2 encounters with me in the span of 1 week, and I've had another patient who has become just barely ready to set their quit date, and we are on the 5th encounter in the span of 4 months. So it really depends on what the patient is needing from me. And also when I use a diabetes REACH curriculum to provide health education for type 2 diabetes patients, these are only 6 2-hour sessions. So that kind of determines the longevity of that. Usually after this specific curriculum, my patients feel secure enough in their abilities to manage their diabetes. However, I have had about 2 patients that have required additional encounters after that REACH curriculum. So sometimes patients that use my services for one thing, let's say diabetes management, will also end up participating in other community health groups I have, like walking groups or Tai Chi Quan, moving for better balance. So it really depends on what the patient wants or needs, and then their outcomes. I'm not just going to leave them there if they still need more.
That's why, yeah, I kind of wondered if it was episodic and then you had to see some other community health worker or that kind of thing. So it sounds like you can build a longer relationship with big gaps in between depending on needs. So that's excellent. Norma, how is it from the payer side of the house?
I think I can really relate to what David was saying earlier, because many of our visits will be anywhere from 30 to 60 minutes, depending on the need. We don't have a cap on how often a member will utilize a community health worker. It's definitely on a case-by-case basis and as needed. We have some folks that we've gone out to see several times, maybe over a month or 6 weeks, and then we might see them again 6 months down the road. It really totally depends on the needs, but we're very open to having our members seen as often as needed to either connect to resources or to engage them into their health care. I think it's a lot like what Dave was saying about the quit smoking. I mean, maybe for some people that might happen really quickly, but for others, it may take longer. So it just depends. And of course, we are dealing with Medicaid primarily, and so a lot of our members, or I shouldn't say a lot, but there's certainly some that move quite a bit, and so just trying to reconnect them and re-engage them. I mean, you might find yourself re-engaging into the same resources, but maybe in a different location from time to time, and we are certainly open to doing that, with our members as needed.
Thank you. Amber, anything to add?
No, I don't think so.
Okay. Thank you very much.
You're welcome.
So our next question is tied to how are your community health workers recruited and compensated? We grabbed Uncle Sam here because, I want you to be a community health worker. But I wanted to kind of find out how you all recruit. Do you go to communities where you're trying to get have an impact, or do you recruit like with job openings and let people come to you? So Norma, why don't you go ahead and answer this one first?
Well, we use a variety of methods, obviously through advertisements, community events, really try to find people that are really involved in their community and like working with people, because of course that's a real hallmark and cornerstone of doing this work. So we've reached out at community events, community health fairs, community meetings and events with other professionals, word of mouth, through our community health worker networks. In fact, I have utilized the community health networker email group that's through DOH training and actually found some people that were interested. Other social service networks and group lists. But really, because we're in the community a lot and talking to folks, we will have a lot of folks actually ask us, what does it take to do this kind of work? And the commonality always is that, as we said earlier, people doing this kind of work have held different titles, numerous different titles, but the cornerstone is that they really want to work with people one-on-one or in groups, and they feel very comfortable doing that, and they can build relationships with folks. And so we have a lot of people actually approach us. They seem very, very interested in the work. And so, like I said, we use different methods to bring in the people, and part of it might be because we're looking to target in a specific area or for a specific outcome that we're doing. So then the skills and previous experience might play in more to it in one area than maybe in another.
Thank you. Colleen?
Yeah, hi. I would agree with everything Norma said. Actually, most of our community health worker roles are staff members, so Certainly it starts with, an announcement, and then we just, many different departments and others are helping to spread the word. But the Promotores program, which work more exclusively with the farm workers in Skagit and Whatcom, they're strictly volunteers, though they're compensated in different ways. But that's more almost exclusively word of mouth and really reaching out to our networks in the community in which we're trying to recruit the appropriate language. That's it.
Perfect. Thank you very much. I kind of have a follow-up question to that. So when you say that they're volunteers, how do you keep them engaged as volunteers? Is it kind of intrinsic to their personalities, or do you have some strategies for that as well?
Yeah, partially, we're looking for the right person who wants to continue to give back to the community and become empowered and learn a lot about different health topics and self-care themselves. So part of it is the character and personality, but no, I mean, we focus a lot on trying to build them up as leaders and recognize their natural talents and skills, and as well as the things they want to continue improving upon. But we do have, we're able to compensate them for trainings and meetings, and they get health benefits, and there's just a lot of personal and professional development opportunities. Within the Promotores team that we have too, just in fact in the last year and a half, 3 different Promotores have gone on to get jobs in different departments in CMAR, utilizing different skills, as well as one even went to nursing school. So we're seemingly becoming a sort of open door to often getting out of farm work for this population, but the promotores that we have we've just seen them flower and blossom, and it's just wonderful seeing them continue to develop and become just more and more self-confident and confident in who they are and in their life. So
that's very exciting. Thank you for sharing that. Okay, so our next question is for coordinated care. Do you support community health worker programs within clinics in your network? And if so, how? Norma? And if you don't, that's okay.
Can you repeat the question, please?
Sure. Do you support clinics within your network to use community health workers, and if so, how?
Well, again, we definitely support that through our provider networks, and again, they just need to reach out to our portal to make a referral, to us. And then we also have staff members that are directly linked to the different providers as well, and they do talk about all of our benefits that are available to all of our members, and also to them as well, to help support them and say, hey, what might be a good reason to reach out, to the community health workers in your organization. And then I'm also available to answer questions. And it's amazing. I mean, like today, although the questions that you're presenting today are the same questions that everyone asks us out there in the community, and they ask us that at the provider offices too, like, are your folks employed? Are they volunteer? Where do they come from? What kind of training do they have? And so I think at this point in time, I think it's probably a real common thread for everyone, is that everyone's just asking these questions and they want the answer to that, and it's about developing that relationship with the provider, just like it is with the community health worker and the patient or member, community member, whichever they happen to be, and they're usually all three. They're just one thing to one person and one thing to another organization, but the commonality of that person who's seeking services, and then we're trying to provide support, by giving education and information and building the relationship with the providers so that they feel confident to reach out to us, and that they have a better understanding as well. What is this managed care organization's community health worker, what is it that they're actually doing, with our patient? What are they talking about? What are they discussing, and how are they doing that? So I think a lot of it right now is just providing that education piece and developing the relationship, and that's how we're trying to provide the support. But we are fairly utilized in our large region in Yakima, and in fact, that's the area where one of my community health workers that's there has lived in the community her entire life, and really well known. I mean, there's just not anywhere that she goes that someone doesn't know her. And so just getting out to provider offices to say, hey, this is one of the persons that's serving, they're like, oh, I know her. So I think everyone can agree. I think it's about developing that relationship, and that's how you can provide support.
Perfect. Thank you very much.
You're welcome.
So, Colleen, this question's for everybody, but I'm going to come back to Colleen for the first response. What lessons have you learned that you can share with us about using community health workers in a clinic setting? We know there's a correlation between some of the socioeconomic factors in health. Can you tell us a story from your experience about helping a patient improve their health? And this may be a question more for David, and I'll let you guys decide that.
Well, I think David can certainly add a story or two, but what I would want to say though is that one of the biggest lessons that has just been reinforced time and time again is that community health workers come in and have many, many different roles and responsibilities and profiles, and so don't put them in one box. CMAR utilizes them in very, very creative ways, and the key is to really be continually creative, because you really want to meet them where they're at, where they are in their life, where they live their daily lives. Some of our community health workers with care management may go out to the patient's home to help them navigate the bus system to a healthier store, or go shopping with them so they understand how, if David and other health educators have taught them how to lower their sugar by reading the food labels, but they still don't really get it, they're able to go out there and actually help them look through the store and find, and put that into practice. So there's very, very different ways in which they can be utilized. I mean, in terms of just personal stories that my programs that I currently manage are more externally based, even though the homeless case managers as well as the promotoras do actually help locate patients or help address different things that providers have referred these patients to them for. But, one of the biggest things that I think is really exciting when you have a prenatal patient who has maybe a second grade education and speaks a different language from indigenous Mexico and shows up and does not know where to go, what the resources are available to him or to her, or even where to go for health care. And you've got promotoras out in the community helping them understand that they can come to our services, they can go elsewhere, they can get specific care, and having not just only a healthy pregnancy, but address many other social determinants of health factors that person is addressing or confronting on a daily basis. And then they are like, this is amazing, I have somebody who I know can help me, and now I don't feel so alone. So my stories are more a lot like that, or somebody who's dealt with dental issues their whole entire life because they haven't had access to dental care, and then getting that taken care of. But let me go ahead and shoot you over to David here.
Thanks, Colleen. And I don't have much to add because Colleen did a wonderful job of kind of explaining that. I do really want to emphasize just the flexibility or kind of the versatility that a community health worker role entails. So one of the lessons I've learned is that clinic buy-in prior to the hiring of the CHW is really important for the CHW program to succeed. Management should have clear expectations for CHWs, like percentage of in-clinic time versus in-community time, productivity standards, etc. And management should also understand the flexibility that this position requires, understanding that the schedules So my schedules are dependent on the community and their needs and when they can make it. So my schedule is not consistently 8 to 5, Monday through Friday. Sometimes I have to do evenings, sometimes I have to do weekends. And this understanding should transcend management so that staff members are all on the same page and understand the role that the CHW has in the health of the patients. And it should also be made clear to CHWs what resources they have to work with so that they can best do their job efficiently.
Thank you. That's really
and
helpful.
Colleen would like to add something as well. Thank you.
Yeah, I just actually want to reiterate actually what David said since I've been here 7.5 years and I've seen some really interesting things come into healthcare and even to CMAR, and really it's just making sure that management buy-in really understands, I mean, at all levels. There can be some real creative ideas thrown out there, but if you just need to have local management buy-in as well as the real understanding, not just buy-in, but understanding the flexibility required and needed with adjusted hours and expectations, because that can make or break a program. That's all I wanted to say. Thanks.
I appreciate that, Colleen. My hesitation that you can hear is debating which direction to go next. I think we'll go ahead and pick up Coordinated Care's response to this question, and then I want to follow up with one of the ones that's been sent in on the chat line. So, Norma, if you want to go ahead and respond to the lessons learned.
Well, I can agree with everything that David and Colleen said, and I think that, again, being very, very creative, I think is a hallmark of this work, and I think the thing that most, I know for myself, I like in leadership in this program, and also I think that all of our staff members would agree too, is that we participate in multidisciplinary rounds. So, I mean, we will participate when the nurse is in their rounds, when they're discussing a certain member, and we can say, okay, how could we interject, what we have to offer with this particular member, and getting ideas, working very closely with quality as well to say, if there's a certain area that we feel like we need to work with folks more on a population base, how are we able to do that? How can we think out of the box? I agree that leadership, and I'm very fortunate that we're very valued here within this company, and we hope to grow over the next few years. But you do have to be able to be creative. You have to be flexible because the tides change out there. People don't change necessarily, but the method on how we're going to reach them, we have some of our members that actually use technology, so being very open to how our members want to connect with us. Maybe they want to do it through texting, maybe they want to do it through phone, some want the face-to-face visits. So just being flexible to all that and making sure that we are providing the type of training that our staff is interested in, and just being open to let people grow, because some people may decide that after they've been doing this for a while, maybe they want to be a champion of diabetes, and that's the thing that they really, really want to work on, or maybe they want to work on asthma, or maybe they want to work on health literacy or fitness, or just health education. So I think allowing folks to, on staff, to be open and grow in the way that they would like to do that. And of course keeping people safe too, because we do a fair percentage of unannounced visits with folks, and just being aware in the community where they are and trying to focus on their job, because we're driving to people's homes and neighborhoods get busy, traffic gets busy, and just remembering that yes, your job is important, but your own self-safety is important too. And so, taking a break for a few minutes, maybe just to de-stress, getting a cup of coffee or a cup of tea, and then getting back on the road again. So just having our staff be safe and continually learning. I know for myself, this is what has happened. I've been continually learning since the day that I arrived here, and prior to being here, I'd worked in public and community health for a long time, and I learned a lot there too, but this has been really amazing at the amount of creativity that people on the staff have had to be able to interface with our members, so that it's a case-by-case basis. It's not a one-size-fits-all, and that would be the other lesson learned, is that it's not a one-size-fits-all. We really have to take the opportunity to look at our members individually so that we can have the greatest impact on them and also on the community.
Thank you. Amber, anything to add? Do you have any stories you'd like to tell?
Yeah, I just wanted to add that for providers, I feel like the community health worker can really be valuable as being a bridge for the patient to the provider world. Just because we're such a less intimidating, we're a real person that's sitting there and listening to that person's story and kind of being able to reframe those messages that the provider's trying to get across to the patient. And just finding a way that they can better connect and relate to their provider. So I think that that's a really valuable role that we can play as community health workers. And yeah, every visit that I go out to, I feel like it's the same story of someone who just needed to be heard and really needed to have that person there that could lead them and empower them to learn those tools into how to better connect with everything in their community. So,
thank you. So for the audience as a whole, if you have questions, it's a good time to go ahead and raise your hand or get those keyed into the chat box. I'm going to go ahead and pick up the first one that Kristen sent in. She's interested in the reporting team structure for CHWs in your organization. So Norma, Amber, would you guys like to go ahead and address that question? What is the reporting structure for community health workers at coordinated care?
So the reporting structure?
Uh-huh.
Well, I manage a program with 5 community health workers right now, and the structure is that I work with them daily. I mean, I am available to them daily to answer any questions, and then we are within medical management, so we work just very, very closely with the care management team, which are all nurses, and I report up to our Vice President of Medical Management. I hope that answers your question.
Well, we'll rely on Kristen to come back with a second one if she has it. Seymour, do you want to go ahead and help us out on your end? I know you've got 7 groups. Maybe take 2 or 3 typical ones and give us examples.
Yeah, well, like my homeless case managers who are out in the community a lot, really they, you know, ultimately the federal government who reimburses for encounters on different types of encounters is really only concerned about the numbers, but, you know, I need to know more so we can continue to modify and evolve the program and respond to new opportunities and streamline issues that were services or things that we're doing that could be better utilized. So, I mean, my homeless case managers report to me weekly we interact, and they can always contact me, or I reach out to them, you know, frequently beyond that. But weekly reports, basically, and through that we continue to strategize and modify the program as needed. The Promotoras, for example, you know, I mean, I have 1 staff member with a crew of 8 volunteer promotoras that are constantly evolving and changing, and sometimes there's more at a different level. But I mean, I just work with that person very closely, and I know what's going on. So in terms of reporting, again, the feds and others internally are really concerned about, you know, the numbers, how many people are being seen that are farm workers. So I have a lot of freedom and flexibility to initiate and implement locally what I think that needs to happen. So that part's good. David, would you like to say something?
Just to add to that, I also have to do weekly reports, and I also do electronic health record charting or reporting, where if it's an in-clinic patient or if it's a patient of CMAR, then I'm obligated to put a note in their chart so that their PCP can read up on it later.
Okay. And how do you all measure success for yourselves? Is it by numbers of contacts? Did you have other measures that you look at? Let's go ahead and stick with Colleen and David for a minute, and then we'll go back up to coordinated care.
Well, I could say, for example, on again, I mean, recognizing it probably varies. I know it varies very different between different departments. Like care management is, for example, looking at the number of clients whose PAM scores have decreased, which was measuring their risk. But like the Promotores program, for example, measures of success are in part by the relationships that we tangibly feel that we're building in the community. Just in the past year and a half tops, we've really uncovered a lot of rich diversity in both counties, and that are highly ethnically, linguistically, and culturally unique, with intense new different barriers than what a traditional, what you would assume a Latino farm worker is. And that has allowed us to enhance our programs or enhance our health centers up here internally by hiring indigenous speaking staff members and initiating other things to help reduce those cultural barriers and linguistic barriers. And by being out in the community, farm workers and the communities are trusting us and coming to us and starting, because these communities historically don't have are very distant with strangers. They're very close communities, which is why they've been able to historically develop linguistically and culturally in isolation. And so really it's just the amount of things that we're being open to and when they come to us. So we're just feeling the difference in the community. Let's just put it that way. And so it's more qualitative success, though ultimately I also hope that, the numbers will be there, and I think they are. Here's David.
Hi. So on a quantitative basis, yes, the numbers are, I guess, what my productivity is measured in. However, within the department, we also have some qualitative measures such as number and length of community partnerships, number of committee positions within the clinic, like health and safety officer, patient-centered health home committee member, Health Week committee member, and also number of health education services offered, the rationale behind why these are offered, and count of community outreach efforts are also taken into account.
Very good. Sounds like one of the indicators that you're kind of using there is how many patients are willing to be on advisory role with the clinic. Is that accurate?
Yes.
Okay,
Yes,
that's
that
what I
is
thought I was hearing, so I wanted to confirm. Norma and Amber. Best measures?
Hi, it's Norma. Well, one of the things that we look at too is reduction of emergency room utilization, and definitely other measures as well. How many actual members that we're outreaching to, how many members we were able to schedule appointments with the PCPs for a myriad of reasons, whether it be well child and immunizations for their children, or helping people schedule a mammogram. And as well, our community partnerships too. We're measuring at our health events that are very specific focused, what our members are thinking. So everyone gets surveyed. Members get surveyed after visits. They're being surveyed also at our health events. And then internally, when we're talking about reporting, we share the same system with everyone here in our building, our staff, in documenting everything so that everything is shared in terms of what we have found and what we're documenting. But really more than anything, I mean, it's the stories that we are capturing, and we do have a format that we do that with, and it's amazing to see how many people in the community will come back to us and say, wow, this was really something profound that somebody learned, or it really changed their change what was happening in their life, or assisted them on to the next, portion of their life system to be able to improve it, whether it be their health, because to us, their health is everything. It's not just their medical health, it's their mental health, it's their oral health, and just their basic everyday living. And so it's amazing to see the stories of folks that give us back some really great quotes following up with them, and then also having many of our care manager nurses come back and just say, I just can't believe it. The information that you were able to find in that hour visit really put together a lot of connecting of the dots so that they could actually help the person with any medical needs that they might have. So I agreed with what Colleen and David said earlier. Some of it is quantitative, but some of it is, probably a lot of it is qualitative too. But I think that we look also for trends and always looking for different interventions that we can try, which does make the work really, really interesting because there's always something, a different methodology that you can use to find out, what is really reaching the patients, and again, being very open, to that. But the success stories really speak for themselves. Thank you.
Very much. It is amazing how diverse human beings are, isn't it? And then one more question, and this one's for CMAR specifically. Since you have so many different CHWs and so many different programs, do you ever worry about duplication of services? How do you avoid that?
Yeah, hi. Well, that's a really good question. I certainly feel like we've experienced that a little bit in the past, and one thing that, for example, when it happened with something that was with a newer program, I just reached out to once I started learning more about it, reached out to the manager, and we just started conversing and talking about and figuring out how they can actually complement each other versus duplication. So it's just really don't work in a silo. That's the key thing with a large agency, and cultivate those relationships cross-sectorally so that everyone can figure out how they can work together and complement each other in the services versus being territorial. So it's really just don't work in a silo.
Do you have any formal structures that accomplish that, especially with the number of sites that you're working in?
No, there's no formal structure. It's it's really, no, there isn't.
And I think David mentioned the multi-disciplinary rounds piece, and that would help with the whole silo piece, but I wasn't sure if with the broader organization you had something too. So I just want to say thank you very much for being on our panel today. This has been a terrific conversation. A lot of good information here, and remind people that it is being recorded so that if you want to come back and listen to it again, it will be available. And you want to go ahead and go forward a slide or two. We talked about that. And we'll do can you do a 2-minute on the training education?
Maybe even quicker than that, Kate. This is Scott Carlson again. We just wanted to remind folks that here at Department of Health, we do have a community health worker training program. Many of you are probably familiar with it, but we have developed our schedule for 2016. It is on the website right now, so we would encourage folks, if interested, if they know of folks that could participate and would benefit from this training, we would encourage you to look at that schedule and sign up if any dates or sites work for you. The training is scheduled throughout the entire state, and so again, this is mainly just for a reminder for folks who might be interested in this. And much more information about our training program, including the topics and the curriculum and stuff, are on our website, which is listed on the slide. So that's all I wanted to mention. Oh yes, and it is free as a reminder. Thank you. So yeah, it's a good resource to take advantage of.
Okay, and then I saw a comment earlier that the links in the box at the bottom left were not being copyable to save elsewhere. If you are interested in getting a copy of those links, please type in your email on the chat box, and we will email those out to you. So we wanted to be sure we followed up with that. And at this point,